or you will be left to smell what coming from them behind. Brother.
With Prime bundles from Digicel, you get more than just data. You level up to a whole new digital life. Level up with D-Music and groove along to all of your favorite music tracks. Level up with Sports Max and catch all the adrenaline-packed live sports action. Level up with Go Loud and tune in to the local radio stations and the most happening podcasts from around the world. And level up with Play Go and get a front row seat to watch the latest movies and TV series. Enjoy a 30-day bundle starting at only $5,400 with 210 gigabyte of dedicated data for premium access to your favorite apps without touching your any used data. Experience the next level of digital. Get a 30-day Prime bundle for $5,400 in the My Digicel app.
This is the news on top of the hour.
Live from our studio in Georgetown.
Kaieteur Radio, 99.1 FM.
The time has now moved on to 13 hours 1, and you're listening to Kaieteur Radio 99.1 and of course 99.5 FM. Kevin Smith here with your news in capsule. The three Chinese-owned companies bidding for the 165 megawatt Amila Falls hydropower project were once blacklisted by the World Bank over fraudulent procurement practices. The companies, China Railway Group Limited, Sino Hydro Corporation Limited, and China Gezuba Group Company, along with Brazilian-owned Realma SA, submitted requests for proposals in early October to the Ministry of Natural Resources at the opening of tenders for the resuscitation of the project, which is slated to begin sometime next year. Checks conducted found that China Railway, which the PPPC government had intended years ago to develop this project, was in 2019 debarred by the World Bank for practices considered fraudulent on a highway project in the country of Georgia. Meanwhile, Regional Chairman David Armagan disclosed yesterday that the New Amsterdam Hospital has commenced an investigation into the deaths of a mother and her baby just hours apart. Dead is 24-year-old Devi Samaru of Bloomfield Village, Quarantine Berbice, and her newborn baby girl. The baby died on Saturday, while Samaru died on Sunday morning, relatives said. They were told by a doctor that Samaru died from hemorrhaging, but the family is demanding justice for their deaths. And also making headlines, government extends curfew to midnight from today despite daily increase in COVID-19 deaths. Climate change will likely reverse gains in Guyana's health and agriculture sector, according to WHO report, and man killed after speaking with foreign women. And according to the official gazette, persons must now be fully vaccinated to enter country and public buildings. Meanwhile, latest global climate report reveals world is in uncharted territory as 2015 to 2021 will be 7 warmest years on record.
And that's the news of the moment. Remember to get the full details of these stories, pick up a copy of the Kaieteur News. And don't forget, you can catch us on the MyTuner app as well as the Radio Garden app. You can also keep up to date by liking our Facebook page at Kaieteur Radio and subscribing to our YouTube channel, Kaieteur Radio Livestream. Oh, also catch our stream at www.kaieteurnewsonline.com/radio.
Keeping your hands clean is one of the most important steps you can take to avoid getting sick and spreading germs to others. So be wise and wash your hands regularly to keep those germs at bay. Get more tips for healthy living by tuning into Kaieteur Radio every Monday at 1:05 p.m. for your health matters.
Kaieteur Radio, keeping you informed.
Demerara and Essequibo 99.1 FM.
Berbice 99.5 FM. Kaieteur Radio.
Good afternoon and welcome to another segment of Your Health Matters here on Kaieteur Radio. I'm your host, Rihanna Ramsey, and joining us today is Dr. Horace Cox. He is the Director of Vector-Borne Diseases at the Vector-Borne Disease Unit at the Ministry of Health. And he will be talking to us about the general control and management of vector services and vector-borne diseases. Good afternoon, Dr. Cox, and welcome to the program.
Good afternoon, Rihanna, and it's a pleasure to be here. Special afternoon to all the viewers and listeners out there. Mm-hmm. I'm happy to be able to share on behalf of Ministry of Health this afternoon.
Okay. We're happy to have you. Just because you're new, and every time we get a new guest here on Kaieteur Radio's Your Health Matters program, we try to give you a chance to tell people about yourselves just a little bit, and then we'll get into our discussion.
Excellent. So I'm Horace Cox for all the viewers out there. I am a medical practitioner. I'm practicing public health for the longest while, infectious diseases. I started within the Ministry of Health at the Georgetown Public Hospital, where I worked as a clinician, and then I transitioned to Mabaruma Regional Hospital, where I worked a year also as a clinician, and then transitioned to a more management role, working at the Mabaruma Regional Hospital as a regional health officer overseeing the health program in Region 1. Thereafter, I transitioned to Georgetown, where I've worked as the Director of Vector-Borne Diseases for the past 6 years. So in this current capacity, I basically oversee the Vector-Borne Disease Program, which entails a number of diseases with which you, the viewers, listeners, would be familiar. For example, malaria. Under the arboviral diseases, we speak of dengue, chikungunya, Zika. I remember back in 2016-15, we had all those diseases, and perhaps we'll chat a bit later on. And of course, the neglected infectious diseases, not forgetting, such as filaria, leishmaniasis, or some may refer to as Busheyer's loosely. So, and we have a few more like Chagas and also self-transmitted helminths. So in reality, it is a huge portfolio and encompasses quite a bit.
Okay. So tell us, what is a vector disease? Because you just touched on a couple of them. And why is control and management important? In our dispensation, in our climate, why is that something that we had to develop a unit for?
Yeah, the reality is, Rihanna, it's difficult in the 21st century to isolate things. And I say that because a lot of times we think that, for example, we can be productive in society without being healthy. And it's not a person's sit and persons believe this is such, but sometimes we feel like, well, I don't need to do X, I don't need to do Y, might not be important, and I can just continue to be productive. The reality is that we have a realm, and we're seeing this with COVID-19 now, of diseases that at times people don't even understand the complexities. And the reality is that vector-borne diseases fall within this group. So what is a vector? A vector is any animal as such that is capable of transmitting a disease-causing organism. And so when it transmits the disease-causing organism, the organism can then infect someone who might not have the protection against it and therefore develop the disease. So to summarize, we want to ensure that we can protect ourselves and understand what vector-borne diseases would encompass and protect ourselves against these diseases, because in reality, the more ill we become, the less productive we are in society, and we'd want to ensure, never mind what disease, once we can do something to protect ourselves against these and prevent them, then we should.
Sure. In terms of the animals, mammals, I'm told, and insects or micro, what do you call them, organisms, what are some of those that we know? Mosquito is one that can spread these vector-borne diseases. What do we need to be careful of?
As you asked the question, I was thinking that perhaps I should share clarification. So you have many vectors, as you mentioned, could be mammals, could be insects. I must mention, for example, some persons will think back to 2005 when we had the floods and persons spoke about leptospirosis, right?
Yeah.
And we know that this is a zoonotic disease that is spread, and the vector could be it a rodent, be it some other mammal. The reality is that that group of diseases would even though vector-borne, they would fall under what we call veterinary public health within the Ministry of Health. So when we speak of vector-borne diseases, under that group, we find mostly mosquito-borne diseases in Guyana. And if I'm just to delve a bit into that, among the mosquitoes, we have even though we have so many, for example, malaria is caused by the Anopheles mosquito, which is the genus, but then you have so many species, right? And not all of them might cause malaria, but the reality is that we basically identify in a simplistic way that Anopheles would cause malaria. Having said that, we have, as I mentioned, dengue, chikungunya, Zika, that basically be caused by the Aedes mosquito. Now, the Anopheles is different from Aedes. To simplify it.
And as Aedes aegypti mosquito.
Yeah, to be specific. Yeah, exactly. So you've done your reading, and I know a lot of persons after we had those programs out would be sensitized as to Aedes aegypti and how those can cause these different diseases. So even though they're mosquitoes, they have different characteristics. There's a reason why Aedes would transmit in our part of the world, arboviral diseases, and not necessarily malaria and etc. Having said that, the Anopheles tends to be more of a nighttime biter. We don't really want persons to go thinking, well, you know what, I'm in the back dam, I'm doing gold mining, and therefore, if a mosquito were to bite me during the day, I wouldn't get malaria. No, that's an error concept. Because the reality is like that any mosquito or any vector, like any living organism, would adapt.
Yes.
So if they can't find humans to bite at night, they will certainly bite during the day, right? So the reality is that we want to ensure that we are conscious that regardless of which mosquito, right, regardless of whether we're talking about the sandfly causing leishmaniasis, regardless of whether we're talking about the kissing bug causing with Chagas disease, we want to ensure that we take the necessary precautions, and of course we can delve a bit deeper into those as the program would progress.
Yes. In terms of precaution, I know your department does a lot to not just spread awareness, but you do a lot in terms of prevention. Fogging, I think, is one of them. Tell us about what some of the activities that you have ongoing so that persons and the public can be safe from these vector-borne.
Yeah, the reality is that what I challenge the viewership and the listenership to do is to understand the change comes by starting at an individual level. So I say all that to say that when we think of controlling the vector, I don't want us to think that, for example, Ministry of Health will be the only entity that's going to be passing through the streets and fumigating, and I know a lot of persons tend to identify with this. And that's the main way in which we control. In fact, I would argue it's an error concept. What we must recognize is that things have changed. The understanding of how disease would emerge and what the determinants of disease and the spread and the transmission, etc. Take, for example, if it is that I have a yard, God forbid, that has lots of tires, old tires, it's raining a lot, we get sunshine some days, what's going to happen once those tires are not perforated, they're going to accumulate water. And the mosquito only needs a teaspoon of water in order to breed. So you'll find that with all those tires not perforated in the yard, raining, collecting water, you'll find that the mosquitoes will be breeding. You have lots of mosquitoes. I say all that to say that the environment is important. And often we think of human health in isolation of environmental health. And when you're dealing with vectors, that's the first mistake that you make. So the first precaution that we should be taking is having a conscious understanding of what we need to do in our environment. And as we address the different diseases, that understanding would change, it'd be modified. Take, for example, when we speak of Aedes-borne diseases or arboviral diseases, we really want persons to ensure, as I mentioned, in and around the yard and in and around the house, that they reduce the breeding sites. So they can perforate the cans that are collecting. If they're tires, they're collecting water, they can do so. If they have stagnant drains, they can ensure that those are free running or water view. For example, if you have the black tanks where we store water, ensure that those are covered because the mosquitoes will just breed. And as they breed, we can go through the streets every night and do fumigation, but they will continue to multiply. And because of that, we'll be working in vain. So we don't want to work in vain. The point is that all these things go hand in hand. So let's deal with source reduction. So what is the source of the mosquitoes? Let's reduce those sources. And then we can look to, okay, well, we have a few still. How can we address that? We can do some what we call larviciding, which is addressing the larval stage. Some persons would know that they've seen workers passing through the streets close to the houses, for example, sprinkling some granules into the stagnant water in and around the house, or they might be throwing a liquid that spreads and forms a film, and therefore kind of like kills the larval stage of the mosquito. And then the last thing you mentioned, which is the fumigation, which is really supposed to be used in a targeted manner, not a routine manner. For example, if there were to be an outbreak, persons would think back, and I know persons remember, it's not a fond memory. When you speak about chikungunya, they remember all the pain that they had in the knee and in the ankle. And when persons think back to these things, for example, you whenever there's an outbreak, you can say, okay, I'm going to suppress the population quickly, the mosquito population. Reason is that it's the adult that bites.
Yes.
And more particularly the female. So if there's an outbreak, let's say there's a dengue outbreak, what we'd want to do is in the zone where we have it, we'd want to go out, have a fumigation exercise to suppress the adult population. But I bring you right back to where we started. We just be suppressing for a period of time if we can't control the source. So it is to say that the primary focus should be source reduction, environmental health, and how we can prevent breeding mosquitoes in mass numbers. If we were to look around and to be honest, there's a lot of room for improvement. And I believe that with appeal and with strong programs and with strategic engagement that we could make those improvements.
You spoke about ridding the environment and how we personally, the citizens, can help you in terms of keeping these vector-borne diseases at bay and having proper vector control. In terms of the stuff that is used, the chemicals, where can we get those, and what are some recommended? Is the unit giving out these chemicals, or do we have to purchase them? What are some of those chemicals that we can commonly use to keep vector-borne diseases under control?
You ask a critical question, and I'll use a simple example. If you go to the doctor would say, it's like you go and you say, okay, what treatment could I use for diabetes, for hypertension? And the doctor would say, even before we go to medical treatment with medicines, let's start with some changes in lifestyle, right? So the doctor would say, once it's not full-blown, the doctor would say, well, let's do some exercise and modify diet, and let's reassess where we are. The reality, it's a similar question you're asking. Could we treat the situation? Could we use chemicals, right? And the answer is yes, we can use chemicals, and the Ministry of Health would make these chemicals available to institutions, not necessarily on an individual basis, but we could also make recommendations as to where persons can obtain the chemicals to use. Having said that, I take us back to the point. We want to reduce the sources. Because if we keep breeding mosquitoes in mass numbers and we don't consciously understand that we're so doing, then all we'll be doing is treating the problem. But while we treat the problem, it's not a definitive treatment.
It's recurring.
So it recurs. And as it recurs, we're stuck in the same cycle, right? And it is a vicious cycle. And in the end, the mosquito will win. So the reality is that even though we treat, we must understand that managing the environment is a better way to go initially, exactly, and reducing the source of the mosquitoes, and also, for example, the stagnant drains, working with the NDC, and for staff proactive engagement. So that's really the way, because even as we treat, the reality is that these things can become resistant to the treatment. And if you abuse the treatment, for example, somebody can say, okay, and this is just a crude example, I'll just dump an entire bucket of insecticide and get rid of everything. Right? But you do more harm than good. So it needs to be a managed delivery and not just a quick intervention that's crude. So it takes us back, and perhaps in Guyana, we're growing in terms of the appreciation of how to care for the environment,
Yes.
and if
Slowly,
we don't care
but
for the environment,
we're
the
growing.
repercussions that can have. So yes, it's slow, and from our perspective, we need to find a way to kind of stimulate that understanding in the periphery.
We spoke about mosquitoes, but they're not the only ones, only insects that spread vector-borne diseases. You talk about fleas and tick, and can you touch on a few more in Guyana? I know mosquitoes are the main
Sure.
ones here. But
So, for example, under the portfolio which I oversee, we also have, as I mentioned earlier, leishmaniasis or bushias, and there we allude to the sandfly. All right. So we tend to see this more in regions 8 and 9 in very remote communities, and they have distinct characteristics. Of course, this is more the sore that never really gets better. It's kind of like this life sore that people try treating it with everything, and for some reason, the last thing to think about is that this could be bushias or leishmaniasis. Eventually, those patients make their way to us, and we manage them. It's a 20-day treatment, getting injections every day. So it's fairly lengthy and can be quite burdensome on the patient, but ultimately there's a high success rate in terms of being cured. So with the sandfly, we are currently developing an understanding from an entomological perspective as to what are the characteristics and how we can manage this vector in a better way. The reality is that there's a lot of research, or room for research in that regard, and we're developing to see how best we can do so by integrating all of these techniques. Having said that, I also spoke of the kissing bug. A lot of persons don't know of Chagas disease, right?
I've never heard of that.
Yeah,
one.
so this is the vector of Chagas disease, and we have a few cases of Chagas in Guyana. Of course, we've been attempting to understand in better detail the true burden of this disease and how we can better manage what's happening, even soil-transmitted ailments. Sometimes persons don't understand that this is actually a vector-borne disease, right? And you would have seen us with our campaigns on lymphatic filariasis, distributing the pills as part of the elimination exercise. So, but of course, lymphatic filariasis is caused by a tiny worm that's transmitted by a mosquito, the Culex mosquito to be specific. So the reality is that we have so many vectors. Even if you speak of mosquitoes, you have so many varieties of mosquitoes then. So it's a question of how do we, as public health practitioners, integrate the techniques, integrate the tools towards an improved delivery of the interventions that we're hoping that will bring us the successes that we so desire.
We know that the vector-borne diseases, they fall under one category, but are they when in terms of like malaria, dengue, chikungunya, Zika, the others, do they exhibit similar symptoms? If somebody has that or they're infected, would they exhibit similar?
And that's why, for example, in medicine, there's something called a differential diagnosis. So a patient can come, and I'll give this crude example and say, oh, doctor, I have headache. And there's so many things, they might think of a million things in that split second. And so they say, no, tell me something else. What else do you have? Because if they were to narrow it down from a headache, so many things can cause headache. And coming specifically to your question, we find that vector-borne diseases, for example, are viral diseases. And there I go to dengue, chikungunya, Zika. More often than not, they tend to be confused. So if you're doing a differential diagnosis, in other words, we're trying to group a number of possible diagnoses so we can narrow things down. These patients tend to present with fever, joint pain, muscle aches, right? Depending on the disease, one or the other could be more exaggerated. At times they can find that there's rash, right? That's developing. And also we tend to narrow it down from how the symptoms appear or the signs appear and how the patient evolves. So the reality is that because there are commonalities, right, we often have to lean upon a diagnostic test to help us differentiate one from the other. Malaria has a slightly distinct manifestation in terms of how the patient would present. For example, it can be a patient with fever, with this cold sweat, with tremors, right? and also depending on whether or not this patient might be complicated and where the patient might be coming from, there might be other manifestations. For example, the urine could be very dark. There could be the blood count could be low. It could be an anemic person. So even though there's similarities, there are distinct differences that can help us to determine whether or not it's one we're dealing with or the other. The reality, however, is that ultimately, in order to confirm the diagnosis, we need to lean upon the laboratory component, which includes using a test that's approved by the relevant authorities that will help us to basically confirm whether this is, in fact, the disease or not.
Are we equipped in terms of performing these diagnostic tests?
Most certainly. For example, you take the case of malaria, right? It's not even a question anymore as to whether the public health sector is equipped, because the ministry has taken to building capacity at a community level. For example, if you were to go to mining camps in Region 1, where we're currently scaling up an intervention, you would find that there are miners in the mining camps that are trained by Ministry of Health to test and treat for malaria, right? And what do they use? They use a rapid test. So we teach them over 2 half-day sessions how to take a finger prick, right? They drop the blood onto this cassette or rapid test, and they're taught how to interpret the result, read and interpret it. And that result is given in 20 minutes.
Wow.
And also, we build their capacity to administer treatment in keeping with the diagnosis. Of course, because this intervention counts on using the layman to help deliver health services by extension, we need to monitor closely and ensure that there is that support, as it's an informal delivery more or less. But the reality is that this is how we're counting on improving access to the services by persons who are at risk and particularly vulnerable.
Yes.
Right? So the reality is that the health services and the public health sectors has evolved to the extent that we now have to think about how to better deliver interventions, and for those interventions to reach the people that are most in need. And so more often than not, it calls for working with the community. For example, you might find, even if not in a mining camp, there might be a shopkeeper close to a mining camp at a landing who can do it, right? And even when we have these, even working with lymphatic filariasis, when we distribute the pills, we work with persons from the community. Some of them are health professionals, yes, but we pair them with persons from the community to deliver. So the reality is that we can't, it has evolved to the extent that we can't just count on persons from within the formal health sector to deliver services, but now we have to depend on the wider community and key stakeholders to take us to where we need to be.
All right, we'll go to a short break. We're talking about vector control and management, and we're speaking to Dr. Horace Cox. He is the director of Vector-Borne Diseases, the Vector-Borne Diseases Department at the Ministry of Health. And when we come back, we'll hear more from him. We're talking about malaria, and you'll tell us a little bit more when we come back.
Sure.
Getting vaccinated is important in protecting yourself and those around you. The COVID-19 vaccine is not a cure. The Ministry of Health's vaccination drive is to remove the virus's ability to cause hospitalization. It helps to look at your exposure to COVID-19 like this. Best case scenario, you don't get infected, and the worst case scenario is death. Get vaccinated today. This is a message from Guyana's Ministry of Health in collaboration with PAHO WHO.
Welcome back. You're listening to Your Health Matters here on Kaieteur Radio. I'm your host, Rihanna Ramsey, and we're talking to Dr. Horace Cox, the director of the Vector-Borne Diseases Unit at the Ministry of Health, and he has been talking to us about how we can prevent the spread of vector-borne diseases such as malaria, chikungunya, Zika, filariasis. Dr. Cox, before we went to break, we were talking about malaria and how you've been working with persons at the community level in the mines, not just for malaria, but to treat other diseases like filariasis. So tell us a little bit more about malaria in terms of the unit meeting its target to eliminate malaria. Where are we in terms of that?
Yeah, thanks so much. So that's a very important question. The Ministry of Health Guyana committed to the elimination of malaria, which is encouraged by the World Health Organization. For example, there's a goal to eliminate malaria as quickly as possible, according to the Global Technical Strategy. And basically, there are a few parameters that they encourage that we adhere to in order to kind of accelerate along the continuum of elimination. So those parameters include, one, ensuring that there's what we call universal access to testing, treatment, and also vector control or prevention. So when we talk about case management, what we're doing there is basically ensuring that health facilities the person go to can test and treat for malaria. And also because we understand that if somebody's in a back dam, more often than not they think, well, why do I have to go out? I can just take medicine. We don't want that.
Yes.
So what we do, we build the capacity close to them to ensure that they can access the services there. So this is what we term universal access. Of course, we need to look at the percentages and see, but currently the Ministry of Health is scaling up interventions to see how best we can ensure that there are facilities that offer the tests, or even community sites that offer the tests, let's say within a mile of anybody who becomes ill, regardless how remote the work site might be. In addition to that, so that's one, universal access to case management, which is testing and treatment. Another is universal access to the vector control intervention. So for malaria, the main intervention, I don't know if some of the viewers or listeners might have heard of the treated net. So the Anopheles mosquito is one, even though they're different biting times, it's more indoor biting. At least the one that spreads malaria in our parts. In addition to that, we find that it peaks more around the time when we want to sleep. So based on the data and the understanding of course, this is something that's ever evolving and we need to check to see what's happening. But based on that data, we need to, we basically distribute a net, which is, the net acts as a physical barrier. So if I'm on the net, it protects me from a mosquito flying and biting me or attaching to my skin. In addition, it is impregnated with a chemical, an insecticide, excuse me, which is what we call permethrin. And of course there are different subgroups. And this insecticide, when the mosquito comes into contact, after a while, being exposed, it will kill the mosquito. So the reality is that it's a double-edged sword, so to speak. So it's two ways of killing the same bird, which is not exactly how we say the cliche.
It's a shield and something that kills.
Exactly.
Like
so it's a physical shield, and also it has the chemical to really help in kill the mosquito. Exactly. So, and what we aim to do is to distribute nets. For example, this year, despite we've had the COVID-19 pandemic and all the challenges that brought, the team has been in the regions distributing nets. It's what we call a mass distribution of nets campaign. And so far we've distributed over 57,000 nets.
Wow.
We aim to, by end of the year, to distribute an additional 20,000 nets. So we've been in regions 1, 9, parts of 7, 8. And we look to complete in those regions. And then also we should be distributing in some parts of region 10. So the reality is that because malaria is such a big problem, even in the midst of the pandemic, the ministry has had to go out and basically be delivering interventions, be it to test and treat, to deliver the net to persons. But one of the things I wanted to tell you is that at times it doesn't quite suffice to just deliver the intervention. What we found is that, for example, Rihanna might be in a mining camp. Dr. Cox might be close by, and so he's there at the site, and so Rihanna, if she wishes, can go and get tested.
Yeah.
But the reality is that because persons feel like, well, I've had malaria 30 times, I've had malaria 40 times.
God.
I know when I have malaria, even though I'm close to you, you don't necessarily access the service.
Negligence.
So the point I want to make is that, and sometimes it might not even be negligence, but persons don't necessarily have all the knowledge that they need in order to make a properly informed decision. So we have been rolling out an intervention with Johns Hopkins University, one on behavior change.
Mm-hmm. And that's in the U.S., John Hopkins.
Well, yeah, they're based in the U.S., but they work with the Ministry of Health to basically improve health-seeking behaviors. So even though Dr. Cox is close to Rihanna, we need Rihanna to access the service. That's physically close. But because of the knowledge gaps, we might be very distant, and you never come to access the service because you don't appreciate that this is a problem. You might be there, but not think that malaria is a disease that can kill me.
Yes.
And that's a reality. And so it's all about, even though we make the intervention available, and it may be physically close, how do we work to improve health outcomes? How do we work to improve health-seeking behavior? And so that in itself is a science that requires a very deep understanding of what are the gaps in the knowledge of the target audience, right? What are some of the perceptions of risk, right? Among other things.
Yes. In terms of malaria, a few years back, let's say 10 years back, we had a certain number of cases. Has there been a decline in your view, or?
So with regards to the cases, what we've seen is that more or less that has stalled, right, in terms of the cases. Of course, there's a very strong effort to roll out interventions that will lead to an acceleration along the continuum, right? So we would expect that in years to come, there'd be a drop in cases because we're basically doing all the hard work now in a coherent way. But the point I want to stress is that even before we get to the point of what's happening with the cases, I mean, this is important. But more important, it would be the whole idea of we need to do things differently, right? And what do I mean by that? If you're a person who's exposed to malaria, be it that you're in a mining camp, or you're in a back dam, or you're at a landing, then you need to access services. If you get fever, don't self-medicate. Go get a test and determine whether or not it is malaria that you have. And if you so do, then you get the adequate treatment. And not just taking the first dose. We want you to complete the treatment.
That's the issue. I was going to get to that. Also, given that we're dealing with COVID-19, you can't just treat yourself for malaria just because you suspect it's malaria, because we have another issue now that arises, and you have to make sure, I hope I'm correct here, and you can correct me if I'm going wrong. You have to make sure that you go to the doctor or you go to the testing site and get tested to ensure that what you're treating with the right medium or medication. As we go along, there's this question about malaria. Well, persons believe that malaria is only you're only susceptible to getting infected with malaria when you're in the interior. But are there cases along the coastline that people can get or have contracted malaria along the coastline? How often is that?
Yeah, the reality is that we certainly don't want to say that there's zero risk. And I'll tell you why. Even though, let's roughly say 95% of malaria cases, all the malaria cases in Guyana yearly, are infected in regions 1, 7, 8, and 9. Right? Let's just say. Even though that's the case, they're infected there 95%. Right? A quarter of all the cases would be diagnosed at central level in Georgetown, at the Georgetown Clinic. So what does that mean? If they're infected there, the grand majority, but yet we have 25% being diagnosed in Georgetown, it means the persons are back and forth. So somebody leaves Georgetown, person X, goes to any given hinterland region, engages in economic activity,
brings it back,
becomes ill, and then returns to Georgetown and accesses a test. And so the complexity is that from the time of being infected, the person then returns and is traveling all the while. And persons along the path could also be exposed if you have a vector, meaning the mosquito, that is competent enough, meaning that it can bite that person and spread the disease. So the only thing missing is to have a competent vector, right? So I say that we can't say the risk is zero along the coast, because when that person comes to Georgetown, for the time that the person is not yet diagnosed and has not yet received treatment, if there's a competent enough vector, then that person could be bitten and then the
Mosquito.
disease could be spread to other persons that are susceptible. So we have had cases that are reported that we've investigated, but the reality is that transmission along the coast is very minimal, right? And we'd want to keep it that way. And we found that the main driver of malaria transmission is gold mining activity. Recently, we did some analyses that show that for every 1% increase in gold price on the international market, there's a 2% increase in malaria cases only a month after looking at falciparum. So for every 1% increase in gold, we jump up. Wow, this is excellent. But there is a twofold increase in falciparum malaria transmission only a month after in mining camps. And there's a 1% increase, which is similar to the price of the gold, in the community 2 months after. So what we've seen is that the increase of gold price on the international market drives malaria transmission in the mining camp, which ultimately drives malaria transmission at the community level, right? So it's very complex. So what we're assessing as a national program is how we can work with key stakeholders within the mining community. And we're currently looking at developing a strategic engagement of these stakeholders so that we can work together to ensure that we can address this problem, which is a concern to all.
I was going to ask about the drugs, the treatment, how accessible, but you already touched on that. So I'm going to ask you, as opposed to other countries, you said that we've been building capacity and we're at a certain level, but in terms of other countries, what would you say our progress is, or where would you say can we be compared to others?
So yes, we could be compared to other countries, for example, along what we call the Guyana Shield. And the reason why I choose the comparison is that we share similar geographical characteristics. For example, we have similar economic activities where persons engage in mining, also in Suriname, in French Guyana, and even Brazil. Also, there's a lot of cross-border movement, which also can be a determinant of transmission.
True.
You have persons that can go from Guyana to, for example, Suriname or French Guyana and do mining activities, and vice versa. We have Brazilians here, we have Venezuelans here as well that engage in mining. So the attempt is that different countries are at different stages. For example, Suriname has a very low level of cases of falciparum, etc. Brazil, of course, they have a lot more cases. Guyana, our population is relatively small. We see about 20,000 cases in recent past per year, but we would want that to drop precipitously.
And that's for malaria.
That's for malaria. About 20,000 cases we see per year. So the reality is that while there are some similarities, there are differences. But what we're doing, countries in the Guyana is basically to work jointly to see how we can address common issues, for example, cross-border movement and how it drives transmission, to develop a strategy to engage the mining sector in a strategic way, so that we can work collectively to address the malaria issues. And the reality is that, as I mentioned, this is a concern to everybody. If you have somebody that has gone to do mining, that's on a camp, who cannot work, that person is not productive, right? And that's time lost. Right? So the reality is they would want to ensure that persons remain productive. We would want to ensure that persons are protected. If they become infected, that they get a test as quickly as possible and that they have access to the right treatment and that they comply with the treatment. So it's what we call loosening Guyana hand, wash hand scenario, and we just are looking as to in what ways could we strengthen that relationship.
In terms of the Zika and the Chikungunya viruses, we also had to deal with that, and I'm not sure where we are in terms of keeping it at a certain level. Can you give us a report on the progress against, in terms of combating or tackling these two diseases?
Yeah, thanks. So Zika and Chikungunya, if you remember what I said earlier, they're arboviral diseases. So meaning meaning that they're a classification called arboviruses, right? But they're spread by Aedes mosquito, and more particularly, as you in an educated way mentioned, by Aedes aegypti. So the reality is that Zika had hit us hard. We had the cases of the microcephaly. That was very traumatizing.
Wow.
Women who were thinking of getting pregnant had to rethink it. And they had so many issues, right? Outside of that, we had also what's called the Guillain-Barre Syndrome, which was a complication where you had persons with this paralysis, the odd cases. But because it was, to put it loosely, one strain, it was, and persons weren't exposed before, it was very explosive in nature. So when you detected one case, you had plenty around, and it came like that. But then it reached the point where it plateaued, right? And persons built immunity to it. And after that, so after plateauing, we basically have not picked up any Zika cases in the past 2 years. It would beg,
how many years?
for the past 2 years, thereabouts.
2
But,
years.
yeah. But it would beg the question of, for example, we also need to look at our laboratory surveillance system and how we work, which is something that we're examining to ensure that we're continuously testing, right, in a routine way. The other thing is, though, even though we're familiar with these particular diseases, we need to think about what about, because as you know, the world is one nowadays.
Yes.
You can jump on a plane, Rihanna, and be in China 2 days from, I don't know.
Yes.
It depends on how you make your stops. So the reality is that we can no longer think that, well, we're safe. So we need to be in a position where we're on top of things, thinking about what else is out there that could come to Guyana that we don't want to come to Guyana, right? And how could we address these things? Because, as I said, you can take a plane and go to France. You can take a plane and go anywhere in the world. And so it's just a matter of hours. The mosquito also can travel, right? You might take an unwanted passenger. You might reach, for example, in Spain, and then when you open your suitcase, there comes a mosquito. So the reality is that it sounds I say it in a joking way,
and it sounds
but it's really to get the message over that we can no
yes.
longer feel comfortable that one disease is way in that part of the world, and we can't. And we've seen what's happened with COVID-19. So if we haven't learned our lesson, well, you know,
everybody knows COVID.
It begs the question: what will teach us?
Language and tongue.
All right.
Yes. We spoke about Zika and Chikungunya, and you were saying that there has been a significant decline, to a point that you haven't seen any Zika cases in the last two or so years, which is quite commendable. And this is as a result of your continuous work in terms of treating and diagnosing the single strain, as you said. It wasn't like, big widespread.
It's several
like
factors.
COVID.
It had to do also with the fact that persons were exposed and they developed immunity. But I want to caution persons because we live in a tropical setting, right? There's rainfall, sunshine.
Yes.
We got vegetation and what have you.
Yes.
And because of those pluses or minuses, depending on how you look at them, you'll always have mosquitoes, right? And because you have mosquitoes, there's always the threat of a mosquito-borne disease, right? Even it just takes one case.
Yes.
Right? And then it can spread once you have, as I mentioned, a competent vector. So the reality is that, you know, we should never feel as if we're out of the woods.
Yes.
Right? Because that's the first error that we'll make. We need to always be planning, okay, if not this, what else could there be? And seeing how we can strengthen. We're working to strengthen the system. And for that system to be responsive to the public health needs that we have. But in order to do that, we must always be in our guard and continue to do hard work. So by no means are we saying that we're totally out of the woods. We can know, because that'd be the first error that we make. As we know, we have mosquitoes in Guyana. We'll
and
have
probably
mosquitoes
would
in Guyana.
never be rid of them.
Yeah, but there are things that we can do to reduce the numbers I mentioned, right? And don't let us just think about the treatment. That's an important facet of it, but we must also be thinking of how do I
prevent
the sources, what we call source reduction. And by reducing the sources, the breeding sites, we will prevent this large number. So it won't be such an explosion. You might have 1 and 2, but not as many as we see.
The Ministry of Health recently as I think earlier this year, last year, I can't remember, but they concluded the Lymphatic Filariasis campaign. I know your unit would have played a role in it. Just tell us a little bit about that and whether or not you believe the target was met in terms of eliminating filariasis in Guyana?
Sure. So, the World Health Organization in the year 2000 would have launched a program, a global program for elimination of lymphatic filariasis. Now, lymphatic filariasis, a lot of persons would know. I remember being a young person and walking through border market and what have you, and you see sometimes the vendors or persons elsewhere that have these disabilities. They can't move as quickly because they have this swollen leg. What persons in the streets loosely call Bigfoot. We've advised against referring to persons in that way to reduce the stigma. But the reality is that this has been a problem, and even though it might not be a disease that may cause the death of someone in short time, it makes people lose years due to the disability. All right, and when I say years, it makes them lose productive years. So somebody who develops elephantiasis or the swollen leg, they can no longer be as mobile. That can affect their employment. It can affect the ability to gain and all these things. So the reality is that there was this global move and this global initiative to, in a very comprehensive way, address the issue of lymphatic filariasis. And it's based on two things. One, the ability to administer pills in a mass way to the population. And these are deworming pills, right?
Yes.
So the Ministry of Health would have been distributing these pills. And even as recent as February, March, we were in 7 of the 10 administrative regions, or 8 of the 10 administrative regions distributing pills to persons. And these are the deworming pills. So there were 3 types of pills, and we were distributing those. And for the second consecutive year, we've had the coverage that's required. We've scored beyond the coverage. So in each year we had over 70% coverage, meaning 70% of the eligible population taking the pills, right? And this has been certainly something that's been applauded. In addition, every place that we needed to implement this activity, we have managed to implement the activity, right? So where does that put us? According to the World Health Organization guidelines, you need 2 successive years taking the what we call the triple therapy. You would have heard so many jingles with the DEC, albendazole, ivermectin. And with the 2 successive years, it makes you eligible for assessment. So we have scored adequately in those 2 years, and we're currently in the process. We're working along with the World Health Organization and other stakeholders. We're going to be assessed to determine whether or not the prevalence of filaria has dropped to the level that Guyana can be deemed free of filaria. We're very optimistic because we've done the hard work. We had a population that was very responsive to the intervention that we were rolling out. And so we, in our minds, we have eliminated filaria, but we are going through the process of being validated as filaria free. That process is fairly extensive because you have a number of surveys that are months apart and what have you. So it can go as long as 3-5 years, depending on how we look at it.
Before
you complete the assessments.
Wow.
Because you're subjected to a number of assessments. And the other thing, remember you're checking to see whether there's transmission.
Yes.
And so you need to do it over a period of time.
Yes.
It's not just one assessment and close out. Because
this disease would show up. It doesn't show up early. It takes a time. I understand.
It can take a while. And the other thing, you're assessing transmission in the population. So the reality is that I think Guyana ought to be proud to know that we've reached a stage where we're being evaluated. And because of the hard work, we should feel some comfort that we've done what's required in order to be assessed and to pass. And of course, the Ministry of Health will keep stakeholders updated as to how we progress.
Okay. We're talking about, back to where we were, general prevention and control of vector-borne diseases. And in terms of the continuous work of your department, tell us a little bit about that, because I know that it's not just seasonal or when there's an outbreak you do your fogging. tell us about the general work of the department, and then you can remind us, because we're about to wrap up, we got a couple minutes more.
Sure.
And you just remind our viewers why it's important that they keep their environment clean, why it's important that they close all water, open water sources, and, spray and make sure they don't have stagnant waters lingering about them. So go ahead, tell us about the unit, and then we'll talk about that.
So the department is named Vector Control Services, which is a slight misnomer because it's really vector-borne diseases, and vector control is a component, which is the response, right? So the vector control is done after collecting the data, and the data says how do you need to intervene to control this vector. Having said that, you asked an important question. Do we just sporadically roll out an intervention like defogging? Is it routine? Are there times when we intensify? The reality is that everything needs to be guided by evidence. If not, then we're just behaving in an ad hoc way.
Yes.
And because we do so, we could be wasting resources.
Yes.
So the reality is that we are building a system, an entomological surveillance system that will help us gather that data in a routine, systematic way that will help guide interventions and tell us when we need to do things and when we need to intensify, and also help us assess how well we've done those things. So the reality is that it's a data-driven world in which we live, and every effort needs to be towards gathering enough data that's of quality that can guide our interventions. Having said that, my appeal to persons is basic. The Ministry of Health is working in order to roll out interventions at country level, depending on the type of disease. We'll have different geographic locations becoming more relevant. But rolling it out is just one component. We need persons to access the services. If you don't access the service, then you have a challenge, because then the service isn't given an opportunity to really respond and to reach the target audience. So we need persons to access the services. We need persons to give a fair opportunity to those messages that are out there that are tailored based on feedback we've received from stakeholders. And so once those messages are allowed the opportunity to work, then we're confident that there will be greater health outcomes, health-seeking behavior, and persons will be able to, in a better way, access services and benefit from what is on offer. The reality is that, as I mentioned earlier, we need to become more conscious of the environment and what we can do on an individual level. Sometimes we want to jump till to the treatment, but we need to take it in a stepwise fashion and ensure that we do the basics. If you're solving an equation, you don't just jump to the final step. You go through step A, B, C, D, and then eventually you come up with a solution to the equation. So the reality is that we need to think of it in a stepwise fashion and understand that it's difficult or impossible to consider the vector outside of the environment. If we do so, then we're setting up ourselves to fail.
Yes.
So we must therefore understand from an environmental perspective, what can we do, starting within our surroundings, within the household, to basically improve how we can manage the vectors the vectors breeding and therefore multiplying. As the name suggests, it's vector control, not vector multiplication. And if we don't do the right things, it's no longer control. What we're doing is a mass production, right? And then we want to spend more monies to try and address an issue which will not be definitively addressed in that way. So my encouragement is that we listen to those key messages and see how we can come on board and join. As I said, there's a lot to look forward to. We want to be free of lymphatic filariasis. We are working hard to ensure one day, and hopefully in the near future, we can come and speak about being very close to malaria elimination, but it'll take great effort. These are complex health issues that we need to address in a strategic way. It's not just overnight. And there are many determinants of how the transmission goes and how basically we need to address correcting them. So, but it's only with the viewers, with the listeners, that we can do so in a strategic way. So my hope is that having listened to the program, it could have helped persons be sensitized to this very fact, and hopefully they can come on board.
Well, thank you, Dr. Cox, for all that you brought to our attention today about vector control and management. To those who listened and joined us on Facebook, thank you for listening. We've come to the end of our program for today, the 1st of November. Do join us again next week. We'll have an interesting show ready for you. And just take good care of yourselves and make sure that we're dealing with COVID-19 and we're talking about vector control. Clean your environment. Eliminate water sources, especially stagnant water. Make sure that your drains are clean properly. Make sure that you cover your water containers so that you don't breed mosquitoes that could spread vector-borne diseases. Get vaccinated against COVID-19. Protect yourself, stay socially distant, and see you on the next program on behalf of Kaieteur Radio. Good afternoon and have a good day.
This is the news on top of the hour.
Live from our studio in Georgetown.
Kaieteur Radio, 99.1 FM.
Afternoon. The time is now moved on to 14 hours to in Guyana. Let's tell you that the 3 Chinese-owned companies bidding for the 165 megawatt Amila Falls hydropower project were once blacklisted by the World Bank over fraudulent procurement practices. Checks conducted found that China Railway, which the PPPC government had intended years ago to develop this project, was in 2019 debarred by the World Bank for practices considered fraudulent on a highway project in the country of Georgia. Meanwhile, despite the alarming number of COVID-19 deaths and cases being recorded, the government has made an adjustment to its measures by extending the national curfew hours from 22 hours 30 to now midnight to 4 a.m. This updated measure, which was published in the official Gazette last Friday, will be in effect from today up until November 30th. The government also extended businesses' opening hours from 23 hours. Some of these businesses are that of bars, indoor and outdoor dining. While the curfew is being extended, the Ministry of Health yesterday reported that 7 more persons who contracted COVID-19 have died.
And that's the news of the moment. Remember to get the full details of these stories, pick up a copy of the Kaieteur News. And don't forget, you can catch us on the MyTuner app as well as the Radio Garden app. You can also keep up to date by liking our Facebook page at Kaieteur Radio and subscribing to our YouTube channel.